We are medicating in the UK roughly only about 20% of those who need medication. This is important to know because oftentimes when we read the newspapers on the media, the headline is increased by 200% of ADHD medication. The prescription rates have doubled or duplicated. But the thing is not that the prescription rate has increased. The thing is, are we covering the need? Are we addressing the need? So they have gone basically, if we look at the past 10 years, the rate of prescription have gone from very little to little. So media highlights this increase. The reality is that there is still a need which is unmet.
Welcome to All Aboard, where we help parents navigate the ADHD journey. Whether you're at the beginning of this journey asking what now, or you've trodden this path for a while and are wondering what's next, All Aboard ADHD is here for you. We will bring you key information from expert interviews alongside parents sharing their real-life lived experience to help you feel less alone. I'm Claire, and today we'll be talking about ADHD medication with our expert guest, Professor Samuele Cortese. Samuele is the Professor of Child and Adolescent Psychiatry at the University of Southampton, an Honorary Consultant Child and Adolescent Psychiatrist for Solent NHS Trust. He is also an adjunct full professor with the New York University. His main research interest is neurodevelopmental disorders with a focus on ADHD. Professor Samuele has published more than 300 peer-reviewed papers, including first author papers in prestigious journals such as the New England Journal of Medicine, the Lancet Psychiatry, World Psychiatry, and the American Journal of Psychiatry, as well as being the consultant editor for the Journal of the American Academy of Child and Adolescent Psychiatry, deputy editor of BMJ Mental Health, and sitting on the editorial board of 4 other international journals. He is the chair of the European ADHD Guidelines Group, as well as co-chair of the Child and Adolescent Psychiatry faculty of the European Collegium of Neuropsychopharmacology, and of the British Association of Psychopharmacology Child and Adolescent Psychiatry module. Professor Samuele was included in the list of the world's most influential researchers of the past decade, with his papers ranking in the top 1% of citations in the field of psychiatry psychology in 2021 with Web of Science, and was ranked the #1 ADHD expert in the world according to ExpertScape. Welcome aboard, Sam.
Thank you.
Thank you so much for joining us there. I'm very excited about this conversation because I've wanted to do a really comprehensive episode on medication since the podcast started. So I'm really, really honoured to have you here today. And if it's all right, I'd like to begin by giving a bit of context for you and for everybody listening, just in terms of my own experiences with ADHD medication as a mum, because I thought that might help personalise all the kind of factual medical information a little bit for people listening. So my son, who is now 13, takes ADHD medication, specifically methylphenidate, with an extended release for his ADHD, which he has done since he was 6.5. So he's been on that now himself for 6.5 years. And when medication was initially suggested by his child psychiatrist, which was shortly after his diagnosis, my immediate response, I think, was one that a lot of people share, and that was a fear of dumbing down my child. I didn't want to kind of medicate him in inverted commas. I didn't want to do anything that would take away his spark and the kind of energy that made him him. And I think just from talking to people, other parents in my support group, that seems to be a common fear that parents kind of initially shares. But obviously over the years, I've learned so much about how ADHD medication works. I've seen firsthand the phenomenal impact it can have on symptoms, especially in the context of a school environment. I know that medication is obviously a very personal choice and a very personal journey, one that no doubt will differ wildly from those listening in terms of their own thoughts and feelings and personal experiences. And I think that's just why I thought it was important to share mine from the offset, because it's just that, an incredibly personal journey. So the purpose of this is just really to give people the facts so that they can make informed decisions for themselves. So I thought thought we could start at the beginning by asking simply, what are the main types of ADHD medication and how do they differ?
Thanks, Claire. And by the way, I fully agree with anything you said in terms of your introduction and the attitude of parents and caregivers, which is fully understandable. And we are here really to provide some scientific data to inform the decision making, which should always happen between the patient, the parents, caregivers, and the doctors. Prescribers. So in terms to answer your question, so basically, roughly speaking, there are two major types of medications for ADHD based on the terminology that we currently use to define them. These are the so-called stimulant medications and the non-stimulant medications. And the name can be a little bit misleading because, sometimes when I discuss about this with parents, they ask, but wait a moment, doctor, my child is very hyperactive. Why do we give them a stimulant? So actually, this refers to the fact that these medications are thought to stimulate some areas in the brain that are involved in attention, concentration, and focus. And so as a consequence, the child will be less hyperactive because they will be more focused. So stimulants have been really the first type of medication that have been used. And then later on came the so-called non-stimulants, which have a different mechanism of action. And I'm not sure if you want, I can discuss more about the mechanism of action of this medication.
Yeah, absolutely. I think you're right about the stimulation thing, because I remember that being my first thought, like, what? He's already very stimulated. So yeah, I think it would be really useful. Would you mind just explaining the kind of different ways in which they work, basically, how they work effectively?
Sure. I will try to explain, of course, in a kind of simple way because there will be many details, but I think they go beyond this conversation. So basically, many listeners may be familiar with the fact that the neurons in the brain, which are these cells in the brain, communicate via molecules which are called neurotransmitters. And one of the most important ones is the dopamine, and many will be familiar with the dopamine. So basically what the stimulants do, they increase the level of dopamine in the space which is between one neuron and the other, so they can communicate better in a way because there is more dopamine. There are two types of stimulant, the so-called methylphenidate and amphetamines. Here in the UK, by far and large, methylphenidate is the most commonly prescribed. In other parts of the world, such as USA and Australia, in some countries, amphetamines are used more. But anyway, so they do quite similar things. So they increase the level of dopamine, but the difference is that methylphenidate inhibit a molecule which is involved in recapturing the dopamine from the system, while amphetamines are in a way a little bit more powerful because also they push dopamine out from the neuron. So the final result is that there is more dopamine in what we call the synaptic cleft, which is the space between one neuron and the other. So more dopamine in some key areas of the brain. While in terms of non-stimulant medications, so we have mainly two types of medications, at least in the UK. These are called atomoxetine and guanfacine, which is the cousin of another medication which is called clonidine, which is similar. So atomoxetine basically increases the level of noradrenaline, which is another neurotransmitter in the brain, especially in the prefrontal parts of the brain. These are the areas in the anterior part of the brain, which are involved in all the mechanism of attention, concentration, focusing, working memory, and so on and so forth. While guanfacine and clonidine, basically they act slightly in a different way, but the final result is still to increase the level of adrenaline mainly. So this is the mechanism of action in simple terms.
That's really interesting. There's some bits in there that I didn't know, actually. So yeah, thank you for that. That was quite comprehensive and still super accessible to understand. So we've kind of covered then the different types of medications and how they work. But what about the difference in release? Because I sort of mentioned at the beginning, my son takes an extended release, and actually that extended release has increased over time with age. So I think initially the version he had, I think it was about 8-hour mode of action, and now it's 12, just in line with his age and his schoolwork and homework and things like that. But kind of what's the difference between the two types?
Is the difference is the amount of hours basically they are active, they are in the system. So initially drug companies put on the market the so-called immediate release formulations because by their own nature, this medication cannot act for several days in a row. So the initial formulation the immediate ones last about 3 to 5 hours, depending on the child. And this is not optimal because, of course, ADHD doesn't stop at noon or 11, right? So we need a coverage during the day. So in order to address this need, drug companies started also marketing extended release and prolonged release formulations. So there are some formulations which duration of action is around 8 hours, and others which duration of action is around 12 hours, up to 12 hours. So this really can cover all day. However, a note of caution, I think, should be mentioned in relation to the fact that these are the so-called average duration of action. In reality, each child metabolizes the medication in a different way. So it's not uncommon that some children, the formulation which is supposed to last 10 hours, lasts actually 6 hours or so on. So there is a lot of variability, and ultimately we learn with parents and our patients how long they last, and we adapt. It's not a precise science yet. We adapt the formulation according to the need of the patient. I don't know if they have a school club in the afternoon or if they don't do anything. Oftentimes parents are okay and say, okay, I'm okay with a 6-hour duration of medication. But
yeah, that's definitely been my experience, that kind of slight trial and error, but also as they get older and the need changes, I think, with age. And obviously that then extended release, that's presumably limited to stimulant medications. Is that right? Because they wash out versus the other class of medication. Can you tell us a bit more about how that works?
Yeah, no, you're right. Actually, when we look at non-stimulants, for instance, atomoxetine is supposed to last roughly 24 hours, so we need to take it once a day. But once again, there is some variability across individuals. And also guanfacine, usually we recommend to take it once a day, mainly in the late afternoon. It can be more effective than if taken in the morning. But once again, we see some variability according to individual characteristics.
Okay, so that variability, and actually in terms of what you were saying at the beginning, how they work in the brain with the neurotransmitters and what it is that the different classes are releasing, like how do you know the effectiveness of ADHD medication?
Right. So currently in psychiatry in general, this is not just for ADHD, we don't use any kind of objective test to check if the medication is working or not. So there is no test like, I don't know, a genetic test or a neuroimaging MRI or a blood sample to see if the medication is working. What we are relying on is the account from the patient themselves and parents, guardian, carers, and teachers. So we gather information and we simply ask, do you think the medication is working? Do you see a reduction in the symptomatology? So there is all an active area of research now in trying to understand how we can use more objective ways to quantify the response to medication. But currently, what we do is basically we take a picture at the baseline before they start the medication in terms of capturing the severity of the symptoms via interviews and questionnaire to parents, the child, and teachers. And then we repeat the same questionnaire after treatment or during the titration of the treatment while we change the dose to see, if there is an effect. And so ultimately it's based on subjective reports. But this is very important because, of course, this is what we do also with antidepressants and other medications, right?
Yeah, it's really interesting, isn't it? Because, as you say, it's your personal experience. And you mentioned that before, even right down to how a child metabolizes something. And when my son was younger, actually, we did have a very brief move from methylphenidate to atomoxetine on the recommendation of his psychiatrist. And it was actually quite reasonably early on. And it was, for us, it was disastrous. It turned him into, the best way I've ever found to describe it was like an incredible Hulk. It was just the most horrendous experience for us and for him. And actually, what you were saying at the beginning in terms of that it works by increasing adrenaline is really interesting to me, because suddenly, for the first time ever, that made sense. But I mention that because whereas in contrast, other people obviously use atomoxetine very successfully, and perhaps in contrast, there are those maybe who vice versa have not had successful methylphenidate. So I guess, why does medication not seem to work for certain children? Is that to do with the way that they metabolize it? Is there other things going on?
I guess this is the $1 million question that we don't have the answer. I'm trying to run a project now, running a project trying to understand exactly this, because as you said, right now we do trial and error. We don't have any predictor of response. I would ideally love to see if, I see little Johnny, their characteristic based on their characteristic, this is the best medication for little Johnny. For little Sarah, given her characteristic, this is the best medication. We are not there yet. This is the concept of the so-called precision medicine, which is more advanced in, for instance, oncology. They are able to target better the medication to the characteristic, but we are not there. And to say that is important, and so think of your experience, to highlight that currently all the guidelines suggest that the first line medication should be stimulant. And if there is no response or the stimulants are not well tolerated, then we should try non-stimulants. So the distinction between stimulant and non-stimulant is also important in terms of using them. And so roughly speaking, if we give a stimulant medication to 100 children with ADHD, roughly about 80% will respond well, between 70 and 80% will respond well to stimulant, methylphenidate or amphetamine. Sometimes they respond to methylphenidate only, or amphetamines only, or to both. However, 20 to 30% do not respond to stimulants. So in this case, 50% of them may respond to non-stimulants. So as you see, we start with the stimulant because it's the most effective type of medication. But if there is no response, or if there is a good response, but unfortunately the child does not tolerate well the medication, we will talk later on about the side effects, then it is recommended to use the other non-stimulant. So ultimately, it's quite rare that we cannot find a medication which is effective, but if we are lucky, we find it immediately. If we are not lucky, it will take several months.
Yeah, I've got some experience of that with parents in my support group. I run ADHD Winchester, which is a local support group, and there are parents there who've had that experience. They've gone through beginning with stimulants and found that doesn't work, then moved on to non-stimulants, and then I can think of one or two who feel they're kind of at that point where the non-stimulants have perhaps not worked for them either. So that's really interesting, sharing those percentages. So kind of guess at what you're saying then, just to make sure I understand, that is about 30% of who try the stimulant medication, that doesn't work for them. They then move on to trying a non-stimulant, and about half of them, it works.
There are still is a very small group of children who do not respond to the common medications we have, but it's a really minority.
Okay. And how common is ADHD medication use actually in the UK in general, and especially in children?
I would say it's not as common as it should be, basically, because we know that the prevalence of ADHD, according to quite solid data, is around 5% of the population of children. Mm-hmm. So 5 children out of 100 have ADHD, which is basically 1 in 20, which means at least 1 in each class, basically. However, 80% of these children do not receive medication. So we are medicating in the UK roughly only about 20% of those who need medication. And this is important to know because oftentimes when we read the newspapers on the media, the headline is increased by 200% of ADHD medication. The prescription rates have doubled or duplicated. But the thing is not that the prescription rate has increased. The thing is, are we covering the need? Are we addressing the need? So they have gone basically, if we look at the past 10 years, the rate of prescription have gone from very little to little. So media highlights this increase. The reality is that there is still a need which is unmet.
That's very interesting. I'll come back to that if I can on the prescription rate, because I'd like to ask you a question about that, but I'll come back to that line of thought in a second. And for those that are on medication, and actually you surprised me then with the percentages that you were saying that 80% of children aren't medicated. So for the 20% that are, how long typically do they stay on medication? And for those that stop, why do they stop?
And this is another big issue we have in terms of medication for ADHD, which is the issue of adherence, we say. So unfortunately, and we have done recently actually a larger research on this, and we saw that if we do a follow-up and we look after 1 year from when they were prescribed the medication, only 20%, 22 actually percent is still on medication. They stay on medication. So the majority, they start the medication, but then they don't continue it. Now, what are the reasons for this? There is no a single reason. There are multiple reasons. In some, is simply that, the nature of the disorder is that they forget to take medication, they're not organized, and the family around is not supporting. So ultimately they start, but they get lost. Secondly, of course, it has also to do with the fact that unfortunately CAM services are extremely busy and crowded, and not always is possible to follow up in a proper way. The other reason is that, and this is especially the case for adolescents, and even though they see a kind of benefit, they feel that the medication changes their personality. They feel constrained. They don't want their life to be influenced by something external like medication. So they refuse taking medication. In some cases, it is because of side effects, of course. We are talking about medication, and it would be naive to think that this medication does not have side effects. However, I would say the good news in relation to the side effects of this medication is that in the majority of the cases, either they're temporary, so they get better over time, or, however, we can manage them without stopping the medication when this is effective. So there are some cases where, unfortunately, some side effects start being noted, and then the young person just stop the medication without consulting the doctor, who may eventually be able to address this. So I would say that, of course, in some cases, we are not able to manage side effects. So we need simply to stop and acknowledge that this is not the right medication. But this, I would say, is once again, is not the majority.
That's interesting. And before we get into the side effects, I think that's really important. What you were saying there about adolescents feeling like they don't want that external influence. So I'm just interested to know, maybe there isn't an answer to this, but what's the difference, or is there a difference between teenagers who start taking medication quite young versus those where it's introduced maybe within their teenage adolescence years? Does that affect whether they retain or keep going with it?
Well, I think that in my experience, but I believe also in the experience of other colleagues, the second type of patients you mentioned is more problematic in a way, because it's difficult to start, because at this age there is ADHD, but there are also the consequences of ADHD over the years. It's much easier to start medication when the child is young, because of course parents are more on board and the child can be less oppositional, so to speak, but is also the nature of the disorder is easier to treat. While in adolescence we have a lot of, unfortunately, negative consequences of the ADHD, which have been working for years, low self-esteem, feeling rejected, I'm stupid, I'm not able to concentrate as others, nothing will help me, and so on and so forth. So definitely I find that working with this second type of patients is more difficult. I would say what really makes a difference in terms of improving adherence to treatment, so make sure that this young person keep on taking medication as prescribed, is really the importance of what we call the psychoeducation of the disorder. So it's not that when I see somebody, I say, okay, you have ADHD, this is a prescription, see you in 6 months. We need to take time, which is crucial, to talk about what ADHD is, what is not, and especially to talk about what that will likely happen if we treat it correctly versus what is going to happen if we don't treat this condition, which unfortunately can lead to quite negative outcome in life, alongside with positive stuff. Yeah.
I completely agree with you on that. I'm always trying to talk in that age-appropriate language to my children about actually what it means to have ADHD and what's going on in your brain. So I think that contextualizing that and having that understanding is so important. So on the side effects thing, before we kind of go into some of the consequences of it, what are common side effects associated with ADHD symptoms that people experience?
So first of all, just let me tell you quickly that, side effects are very important, but I think there are two dangers there. So the first is overestimating side effects. This is not good because it will prevent somebody from getting medication, which may be helpful. The second, of course, is underestimating side effect, which is equally, a negative attitude, because, of course, we may expose to risk somebody who, of course, who does not want to be exposed to these risks. So in terms of side effects, as I mentioned, the majority are temporary, and the two most common ones with stimulants are decreased appetite and difficulty falling asleep, even though in some cases actually medications for ADHD may help sleep. Because if we treat ADHD in the evening, the child will be less hyperactive and then more keen to go to bed and fall asleep. But they are stimulant medication, as we say, so they stimulate, they increase the level of arousal, of alertness. So in general, we should avoid them in the evening. So these are the two most common side effects. So reduction of appetite, difficulty falling asleep. There may be also other side effects. Sometimes we have headache, tummy ache, and paradoxically, in some children, more irritability. So they become more irritable, which is something we don't want and we don't expect. In general, those who have this reaction to this medication have also other disorders that we say in comorbidity, so associated with ADHD, notably autism spectrum disorder or intellectual disability. So in these cases, we need to use very low doses and increase the dose quite slow, in a very slow way. But these are the most common side effects, I would say.
That's really interesting. So am I right in understanding what you're saying there, that actually the children that typically experience increased irritability from stimulant medication are typically those who might have something like autism as a coexisting condition?
I mean, typically these are, for some reason, because their brain is different, the way the network of the brain are organized, they tend to tolerate less well medications for ADHD, unfortunately, even though, some they benefit and is an important help in their life.
That's really interesting. So the other two, decreased appetite and the impact of sleep, definitely something I've experienced with my son. But I think we've managed to kind of balance the dosage with that on him over the years, so that you're kind of getting the right dose that positively impacts symptoms, but almost without overdoing it, particularly from a sleep perspective. I think appetite will always slightly be one in the middle of the day with him, and we kind of manage that as closely as we can just to make sure that he's eating. And actually, now that he's getting older, he's 13, I'm really trying to raise his awareness of why that's so important about monitoring his weight in relation to his growth, because of it in terms of the side effects, and then being able to access the medication, just to try and give him a sense of autonomy and I guess a responsibility for thinking, am I eating enough? Because I can also see the impacts on that if he doesn't. But they are ones that we've definitely experienced. So we kind of obviously talked about the way in which that works and the side effects and things, and you talked a little bit about consequences, but I was going to ask you what the long-term risks are, if any, from taking medications, or indeed the benefits, which actually might lead more into the consequence stuff that you were talking about.
Yeah, no, absolutely. It is important to talk both about the benefit and the risk, because ultimately, as with any medication, it is a trade-off, a balance. We need to balance the benefit and the risk. There will be no medication without possible risk, but if the benefits outweigh the possible risk or the actual risk, then I think we are okay in continuing this medication. If the medication is only bringing risk and negative side effects, then clearly it does not make sense to continue. So what do we know from our research? We do have a large body of studies on the short-term, what we call the short-term effects of this medication in terms of a few weeks or months, because we have a lot of what we call randomized control trials. So randomized control trial is the best type of study to really understand the effect, positive or negative, of a medication. What we usually do in the randomized trial is that we, as the name say, randomize, so we assign by chance some individuals to take the active medication, the medication we want to study, and others, they take a placebo, which is something which looks like the medication but is not effective. So this is the only way to understand if the medication has some positive or negative effect. However, randomized controlled trials are expensive, and this is why it's not ethical to randomize somebody to placebo for years to see the effect, right? Because we cannot randomize somebody. It's not ethical if we know that the medication is working. So these randomized controlled trials are informing us on the effect of the medication in the relatively short term, weeks, months. What they tell us is that these are the most powerful medications we have in psychiatry to reduce the severity of the symptoms of ADHD, so to reduce the hyperactivity and to improve attention and concentration. They also are able to improve other aspects of which are important, because a child with ADHD is not just inattention, hyperactivity, impulsivity, a human being with other aspects in their life. So what these trials tell us is that this medication reduces also the severity of emotional dysregulation, so difficulty in regulating emotion. They improve what we call the executive functions, so working memory and all the other abilities that are needed to start, continue, and complete a task. And also overall, this is a recent research we published, they improve the overall quality of life. However, what these studies also tell us is that the effect on quality of life, emotional dysregulation, executive dysfunction is less evident compared to the effect on the symptoms of ADHD, which are the famous 3 symptoms that many parents know, so inattention, hyperactivity, impulsivity, which tell us that medication should not be the only approach we consider to improve the overall quality of life of these children. But these are good data. In terms of the risk of this medication from randomized controlled trial, what we know is that they can increase side effect more than placebo. But interestingly, when we look at the analysis showing how many children leave the trial, so they are withdrawn because they don't want to take part in the trial because of side effects. This is the same in those who take methylphenidate versus placebo. So overall, there is no significant difference. This is everything we know from the randomized controlled trials. However, when somebody has ADHD, they don't take this medication just for a few weeks or months. They take oftentimes for years. So the question is, what are the effects, positive or negative, of this medication in the longer term? We cannot address this with trials, but there are new type of studies, quite complicated, so I will not go in detail, which rely on data more in the long term. And what they show is, for instance, a reduction in the mortality. This is very important. So unfortunately, if we follow them up over time, individuals with ADHD are more likely to die compared to others, because of car accident, for instance, unintentional injury, so on and so forth. This is not to say that everybody will die, but if we look at statistically, there is a higher chance. Once again, overall the risk is still low. I don't want to get our listener to panic, but overall, we know that ADHD, if not treated, unfortunately, is associated with higher risk. Now, we know that medication decreases the risk in the longer term. Finally, the final piece of information we have from these long-term studies is the effect on the cardiovascular system, because this has always been a concern of this medication. We know that in the short term, they can, in some children, increase blood pressure values. This is why you will know very well, Claire, that when your child used to go to follow-up medication review, they measure blood pressure. And this is, once again, in some cases, this increased blood pressure is quite important, but in the vast majority of cases, is not important. So we simply monitor. Now, the question is, if somebody keeps on having this light increase in blood pressure, is this a stress for the cardiovascular system? They are also more prone to have other cardiovascular disorder, heart attack, and so on and so forth. So now the good news is that this has not been found in the long-term studies. So basically, the recommendation is keep on monitoring the blood pressure. In the majority of cases, there will be small increases which are not clinically relevant. In a very small percentage, it will be cautious to stop the medication because the blood increase values are more relevant. But once again, this is a small portion of all those who are treated.
Okay, so just make sure I understand that correctly, that a small portion of people it can affect blood pressure and cardiovascular issues in the long term, but typically what the data you've got and the studies that you have so far from long-term use show that actually, rather than there being risk of long-term use, there's actually real benefits to for long-term use to those that have ADHD because of some of those negative consequences that typically come with it, like you said, like an early death, car accidents, and so on.
Right. So when we balance the pros and the cons, the benefit and the risk, clearly this is in favor of the expected benefit of this medication.
That's really interesting, and obviously very positive to hear, as someone whose son's been on medication since he was 6.5, and, for the most part, very positively. And just to touch on the symptoms element you were talking about, I thought that was interesting too, because you're saying that obviously significantly, the biggest improvement is on the ADHD symptoms themselves, but actually alongside that, medication also does positively impact things like emotional regulation or dysregulation and those executive functions. Is that correct?
Yeah, I think historically the focus in research has always been on the famous 3 symptoms of ADHD. Then, of course, researchers and clinicians, of course, knew very well this. They realized that it's important to focus on other aspects in life because, it's not enough just to decrease the symptom, the severity of hyperactivity. What we want is to improve overall the quality of life and the well-being, of these children and their family. Ultimately, this is the goal, the ambition. It's not just to reduce the severity of the symptoms. So in doing so, we see that, yes, medication can help on these other aspects, but with an impact which is less evident compared to the impact on the core symptoms of ADHD, inattention, hyperactivity, which tell us that to manage properly and in a comprehensive way and help these children, we need also other types of intervention which depend on the specificity of that particular child, that particular family. So medication is a good, important help, but oftentimes it should not be the only answer and the only approach that we consider.
Yes, it's really interesting that you say that particularly on the emotional regulation side of it. My daughter's 9 and she very recently had her ADHD diagnosis and, isn't yet taking any medication, but actually she presents quite differently to my son's. Although she still has a combined type, she doesn't at the moment, at the stage she's at, have the same struggles academically and in the classroom as he perhaps had. But where we really see her difficulties a lot is in emotional regulation. So actually hearing you say that is really interesting to me, because it helps me build my picture and understanding of the uses of medication beyond just, as you say, those kind of 3 big symptoms that come with it. And just one final question on that then, and does that differ by medication type, those outcomes that you're talking about? Is it stimulants versus non-stimulants, or is it the same across the two?
No, so far the data we have do not suggest any specific important difference on this other outcome, but we need more research to better understand this. This is also one of the goals of my ongoing research, so hopefully I will be able to tell you more in a few years.
Yeah, well, on your ongoing research then, and you mentioned that a little bit earlier about the way in which children metabolize things and the kind of trial and error process that we mostly go through. So I know from what I've read that in the future you're talking about moving towards precision medication, which it feels like it might be particularly important for children given the young age from which they're taking medication. So can you tell us a little bit about what is precision medicine and how it could be tailored to meet individual needs?
So this is actually a big change that is really being seen now in medicine. And so the idea is that to tailor the right medication to the right person, the right time, and for the right outcomes. So basically, as you said earlier, right now we are still doing trial and error. We try medication. If it works, we are lucky. If it doesn't, we try another one, and so on and so forth. This is very time consuming, and we would ideally like to have some predictors, we call them, which can guide us in selecting the right medication from the very beginning, so to avoid this trial and error process. We are not there yet, of course. As I mentioned, there are advances in this in other fields of medicine, such as, for instance, oncology, because there we know much more about the genetics, the characteristic of these conditions. So we can use all these characteristics, like particular genes which are changed in this disorder, particular characteristic, to use specific medication that go and act on those particular characteristics. We are far behind in the field of ADHD and psychiatry in general. So what we can do now is a first step toward what we call stratified medicine, or stratifying the treatment. What does it mean? To look at if, based on specific characteristics of subgroups, we can identify medications that are more likely to work. What do I mean? For instance, we know that current guidelines says that methylphenidate, as I mentioned, should be the first line treatment. So we start always with methylphenidate. But what does it happen if a child has ADHD and on top of this also, for instance, autism spectrum disorder? Is methylphenidate still the best first choice or not? Based on these characteristics, which are mainly associated disorders, sex, gender, age, other medications that they take, can we find the medication which is more likely to have good effect? In the future, the ambition will be to go to work more, what they're doing in oncology. So using, for instance, genetics. So if we can do genetic tests to understand, based on specific mutations in specific genes, can we recommend a specific medication? But currently, there is no solid science to inform this. You can see on the internet there are some genetic kits that are sold for this, but there is no really solid science on that.
Oh, that's really interesting. I think it's exciting as an idea, isn't it? Particularly with children, that actually when we can get to a stage where we know more an individual personalised level, that we almost don't have to put them through the process of trial and error with drugs and the impact that has on them. And then I guess also on kind of family life and the dynamics while you're kind of going through that. So it's obviously in the future, but when do you imagine something like that might be a reality?
I mean, it may become a reality sooner than later due to the advances in machine learning, artificial intelligence, which are really speeding up. What we need is that so far we have relied on relatively small studies, and each center, each investigator, they have conducted their own studies. We need to share data because to go there, we need a very large number in terms of individuals who are involved in studies. So parents who are listening can contribute in volunteering in studies, but also researchers who are working on this should really have kind of a change in mindset and sharing their data rather than keeping their data for them, sharing the data so that we build a large data set, and large amount of data will make this easier.
Yeah, absolutely. I do always try actually through my platform for the podcast when I see studies where they're looking for children and parents and families to participate, because I feel like if we want these changes, it's important that we contribute as much as we can. So just to kind of go back to what you were saying a little bit earlier about prescription rates, because I wanted to pick that back up with you, given that it's such a crucial treatment, as we've kind of established from this conversation, obviously not the only part of the puzzle, but it is quite crucial. We've been suffering in the UK with a medication shortage for like well over a year now. And, speaking as a mum, it just feels so exhausting because it's like our children, things are hard enough for them as it is, particularly in a school environment. So to have access to medication taken away, for want of a better word, or certainly severely impacted, is, to use an analogy I know that is often used with medication ADHD, is like taking someone's glasses away and expecting them to still be able to see clearly, particularly in a classroom sense. And then I know from our personal experience that just tracking down medications is a job in itself. So in your opinion, given also actually that you said that such a small percentage of children with ADHD are actually taking medication, what is causing the shortage in the UK and what can we do about it?
Well, I think this has been extremely unfortunate circumstance that we are living with for more than 1 year now, 18 months. And it's not just specific to the UK. It happens in other countries, and not just for ADHD medications. It's the case also for other medications. But clearly, it has been very disruptive for ADHD. And as I say, it's very negative event. The only positive event, so to speak, from the research point of view is that there is a lot of controversy on this medication, are they good or not, and the evidence. This has been a natural experiment, so to speak, that showed that, clearly this medication brings a benefit. We have this
interesting
evidence. For me, this is the only positive aspect of this. But coming back to the reality, and it has been really disruptive. We know this from the clinical practice. The causes are complex. We have heard different opinions over the months, but basically it has to do with two main factors. On the one side, the fact that drug companies were not able to provide the right amount of supply due to limitation in the way they can really produce these medications, in part affected by the pandemic, because to produce medication you need materials, and you need an infrastructure which has been impacted by the pandemic. And on the other hand, of course, there's been a massive increase in the number of diagnoses. And as we mentioned earlier, probably this is due to the fact that we are finally increasing awareness on the existence disorder, so we are diagnosing more and more people who actually have the disorder. However, there are also cases where we are misdiagnosing. What does it mean? That we are labeling somebody with ADHD where actually it's not ADHD, there are other causes. So it's important to diagnose correctly ADHD, but also to do what in medicine we call a differential diagnosis, which means that those who look like ADHD but have other problems like, I don't know, trauma or other condition, they should receive the correct diagnosis. So we need to pay attention to this as well. So I think that to address these, there are actions that governments and drug companies and other key people involved in this can take, but there also is also our responsibility to correctly diagnose ADHD when it's there, when it's a real ADHD, but also not to diagnose it when the cause is somewhere else.
And it's hard as a parent because you're at the kind of bottom of that chain and you feel like you want to do something to positively impact it and change it. But it feels like perhaps needing to put pressure on government to at least give us some answers so we have some visibility and understanding of what's happening and kind of what's coming. You were saying, obviously, medication is just one piece of the puzzle, right? Like we need a holistic approach. Mm-hmm. So how do you see medication fitting into that broader holistic approach from your perspective?
Well, when I inform my patient after the diagnosis has been established and we need to decide together what to do, because it's not me as a doctor who decides, it's a shared decision making, I always like to tell them that basically, and to children, of course, that basically different approaches, different treatments, we have tackled different aspects. So medication, as we said earlier, is very good to reduce the severity of symptoms of ADHD, improve attention, decrease hyperactivity. But many children with ADHD, for instance, they struggle with oppositional behavior, which in some cases go up to conduct disorder. Family dynamics are always problematic because, of course, the presence of the disruptive disorder has an impact on family dynamics. In this case, for instance, the so-called parent training program or behavioral programs, like, for instance, the New Forest parent training program, which has been developed by Solent NHS, or the Barclay program from the United States, or other behavioral programs, they're very helpful to tackle these aspects of oppositional problems, family dynamic, improve parenting. So likewise, we said earlier, medication can improve executive functions, but is not the only answer and is not fully effective on this. So there are, for instance, programs of cognitive training that may address it. So I think we really need to integrate, and what we propose is based on the understanding of what's going on, what we call the formulation in psychiatry. So, if we see a child in a family with a lot of particular family dynamic, then family therapy may also be an option. But this is not the standard for other children. So we really need to tailor this to the specific characteristic and to think that medication is an important help, but it does not address all the aspects that we want to improve.
Absolutely. And education, like you said earlier, I think ADHD coaching as an example is great because that helps build those skills around executive function and understanding specifically through that ADHD lens. You kind of understand what's going on for yourself and are able to learn how to develop skills to navigate that stuff. So, I mean, what one final piece of advice would you like to leave parents listening to help them on this ADHD journey with or without medication?
I would like perhaps to go back to what we were mentioned at the beginning, your own experience that, you felt a little bit lost or scared, they're proposing medication. I would say don't feel lost, don't feel scared. Read, get good information. These medications have been used now for more than 70 years. Mm-hmm. This means that, they have never been retired from the market for concern around side effects. They're still there after 70 years, which means that we have a large body of evidence informing the effect of this medication. And overall, if we look at the trade-off, the balance between positive and negative effect, this is clearly in favor of the positive effect of this medication. This doesn't mean that 100% of children with ADHD will respond well to this medication or will tolerate well this medication, but it's very likely that they will have a benefit if this medication is used correctly and within a more holistic and comprehensive management care plan.
Thank you so much, Sam. You said comprehensive there, and I think that's exactly what this episode has been. And I think I know a reasonable amount about this stuff, but I've learned so much from you today. And I have no doubt for parents listening, it will just help them have this really solid, evidence-based, credible foundation from which to build this picture for themselves and understand what their children need and what's going on for them. So thank you so much for your time. It's such an honour to have you here today.
Thanks for having me. Thanks. Feel free to contact me again if there is any need of additional information. Thanks a lot.
If you'd like to learn more about ADHD medication and Professor Samuele's work, then please do check out our show notes below for more information. Or if you'd like to find out about how I can help support you and your children with personalised ADHD coaching, then please do head to allaboardadhd.com. You can also find me on Instagram at allaboardadhd. Most importantly, if you enjoyed this episode and found it helpful, please can you follow and review All Aboard to help other parents find this podcast and welcome them aboard our journey too. Thank you for listening to All Aboard ADHD.